Good morning, ladies and gentlemen. The topic of today's lecture is perforating dermatosis. So the perforating dermatosis is the skin disorders in which dermal material, which is degenerated collagen or elastin, is eliminated by extrusion through the epidermis by a process that is known as the transepidermal elimination. The primary perforating disorders are particularly associated with diabetes and chronic renal failure. And in case of acquired perforating dermatosis and heritable disorders of connective tissues, or Down syndrome in case of elastosis, perforans, serpiginosa. So the associations are mainly diabetes, chronic renal failure, the inherited connective tissue disease like pseudoxanthoma elasticum, Ehlers-Danlos syndrome, and Down syndrome. Transepidermal elimination. It is a term which is used from the material from the dermis that is extruded through the epidermis to exterior with little or no disruption of the surrounding structures. This extruded material may include altered connective tissue components like collagen or elastic fibers. It includes the inflammatory cells, the red cells, microorganisms, or mucin. Etiology. The primary disorders might be due to defect in epidermal keratinocytes, hair follicles, collagen, or elastic fibers. In acquired disorders, the bulk of the coarse granular basophilic material appear to be derived from the nuclei of polymorphonuclear leukocytes, means the inflammation has a key role. It is suggested that lysosomal enzymes derived from the leukocytes are responsible for alteration in collagen fibers, the degeneration of elastic fibers, and impairment of keratinocyte adhesions that allows the transepidermal elimination of the dermal components. There are different kinds of perforating dermatoses. The primary perforating dermatoses are primarily four types. The reactive perforating collagenosis, which is now known as the acquired perforating collagenosis, perforating serpiginous elastosis, perforating folliculitis, and Kyrle's disease. Now, Kyrle disease is also considered to be a part of acquired perforating collagenosis. Then, perforation is associated with certain skin diseases, which include granuloma annulare, pseudoxanthoma elasticum, lichen iridis, and chondrodermatitis nodularis. It is associated with systemic diseases like diabetes, chronic renal failure, especially undergoing hemodialysis, and liver failure. And perforation is also associated with exogenous chemicals like drilling fluids, ECG paste, and intradermal steroid injection. There are few revisions of terminologies. The term perforating folliculitis continues to be used in the published literature as a disease entity, though several authorities have recommended that it should be abandoned. So the perforating folliculitis term has also become questionable. Then the term acquired reactive perforating collagenosis fell out of favor some years ago to be replaced by acquired perforating dermatosis because it was demonstrated that not only collagen but elastin is also extruded in this case. So the term of acquired perforating dermatosis is preferred. Similarly, the distinction between the acquired perforating dermatosis and Kyrle's disease is also not clear-cut, and separation of two is no longer felt necessary. However, we will discuss these, the perforating folliculitis and Kyrle's disease as separate pathologies, but now they are no more considered to be separate pathologies, and the two important perforating dermatoses are the acquired perforating dermatosis and elastosis perforans serpiginosa. So the acquired perforating dermatosis, which was previously known as acquired reactive perforating collagenosis. An acquired disorder of transepidermal elimination of degenerated collagen, elastin, and other connective tissue components. It is strongly associated with diabetes and chronic renal failure. The relatively frequent in commonly affected population with the reported rates of 4 to 11% of patients on hemodialysis. It occurs in 5th to 6th decade, and female to male ratio is 3:1. So more common in female and usually in older age. So associated disease, they already mentioned twice, there is a strong association with chronic kidney disease and diabetes. Cases are also reported in association with dermatomyositis and drugs known as natalizumab. The clinical features. The acquired perforating collagenosis is characterized by the keratotic dome-shaped papules with a central crust that can develop anywhere on the body, but primarily on the extensor aspects of limb and trunk. Pruritus can be intractable and is a common symptom. Reactive perforating collagenosis, there you can see in the picture that there are multiple pink papules, some showing central umbilication with crust. Small scattered crusted papules are present on the dorsa of the feet. As crust is removed, the lesion heals. So the dermoscopy is interesting. The dermoscopy shows the yellow-brown structureless areas in the center of the lesion, keeping with the surface crust. So this is the yellow-brown crusted areas. Then there is a white rim surrounding the crust of variable thickness, and outer pink circle of inflammation with visible vessels. So 3 features, that is a brown crust, a white halo, and a zone of surrounding erythema. If we go for histopathology, there is the transverse section through center of the lesion shows a large crust that is comprising of parakeratotic debris, degenerated collagen, and inflammatory cells and multiple points of incipient perforation. These are the points of perforation. So you can see these perforating channels. And the collagen fibers are penetrating the epidermis, an epidermis which is atrophic. So the collagen bundles are penetrating this atrophic epidermis and are extruding out. If we do the Mason trichrome stain, the collagen fibers are highlighted and seen here as the material extruding out of they are vertically oriented and extruding out of the atrophic epidermis. Familial reactive perforating collagenosis. This is different from the acquired reactive perforation, and it's a rare inherited form of transepidermal elimination. It is precipitated by environmental cold or trauma. The basic defect seems to be a type of focal damage to collagen, which is then extruded as a result of necrolysis of the overlying epidermis. In some cases, the disease is associated with intolerance to cold and improves in warm weather. The central crater, which develops, contains inflammatory cells and keratinous debris as before. Elastic tissue is typically absent in familial reactive perforating collagenosis. The condition persists into adult life. It usually starts in childhood as a small skin-colored papule on the extensor surfaces of hands, elbows, and knees. Each papule increases to about 6 millimeters over 3 to 4 weeks, then become umbilicated with keratotic plaque. The lesions regress spontaneously in 6 to 8 weeks and leave hypopigmented areas or slight scar, but new lesions keep on appearing. Koebner phenomena may result in linear lesions. There is another type of perforating disorder, which is the Verrucous perforating collagenoma. Again, a rarely reported condition, appeared to be a reaction to traumatic induction of foreign material, which include fiberglass, vegetable matter, calcium chloride, and irritant drugs into the skin. And the damaged collagen is extruded by transepidermal elimination, and it is manifest as verrucous plaques rather than keratotic plaques. Perforating diseases due to exogenous agents. occasionally a chemical, which is applied to the skin topically or by intradermal injection, can be eliminated by transepidermal route. Each patient noted skin irritation following exposure to the fluid, and 1 to 2 later, that we are talking about the drilling fluid, and 1 to 2 days later developed tender papule with central umbilication, followed by ulceration and crusting. Histological examination revealed the transepidermal elimination of collagen and debris which are stained with calcium. It is possible that lesions are due to follicular penetration by calcium present in the drilling mud, and the drilling fluid contained many other additives, but calcium carbonate and calcium chloride are the main ingredients and are main component of this mud, which result in this transepidermal elimination. Similar cases are reported following use of calcium-containing electroencephalography paste. Transepidermal elimination of altered collagen has also been reported after the use of intradermal steroid injections. Management. Some patients improve spontaneously, particularly when the renal functions are restored. No particular treatment is of proven benefit. However, the oral treatment includes allopurinol, isotretinoin, methotrexate, or rifampicin. Topical treatments include tecalcitol, retinoids, emollient creams, intralesional steroid, and topical steroids under occlusion. Narrowband UVB, PUVA, or photodynamic therapy are also being used. The associated uremic pruritus improves with amitriptyline. Then Kyrle's disease. Although I have mentioned before that Kyrle's disease is no longer considered to be a separate entity and is now classified as acquired perforating dermatoses, we will explain this disease a little as it is done in the Rook. A rare skin disease and is classified as a subtype of acquired perforating dermatosis due to significant clinical overlap, both follicular and non-follicular morphology, and variation in histology with different disease stages. Acquired perforating dermatosis was proposed as an umbrella term for adult onset perforating disorders. However, there is a controversy in literature as to classify Kyrle's disease. While some authors use Kyrle's disease interchangeably with acquired perforating dermatosis, others define it as a variant of prurigo nodularis and represent an end stage of excoriated folliculitis. You can see these keratotic papules. These are the follicular papules rather than and follicular and rather smaller with a big keratinous plug. So morphology is a little different from acquired reactive dermatosis, acquired perforating dermatosis. Then elastosis perforans serpiginosa. It's a perforating dermatosis in which the material extruded through the epidermis is derived from elastic fiber rather than from the collagen, and present between 5 to 20 years, rather younger presentation, and males are predominantly affected. Some 40% of the cases are associated with heritable connective tissue disorders like pseudoxanthoma elasticum, Ehlers-Danlos syndrome, Marfan syndrome, osteogenesis imperfecta, and acrogeria. And it is also reported in association with Down syndrome and sometimes in patients receiving penicillamine. The pathophysiology. The primary abnormality is in the dermal elastin, which provokes a cellular response that ultimately leads to the extrusion of abnormal elastic tissue. It may be significant that lesions are commonly seen in areas which are subject to wear and tear. The epidermis is markedly thickened and multiple basophilic elastic debris is present in the papillary dermis. So you can see in this picture, taken through the center, that characteristic tortuous perforating canals are seen. Note the degenerated elastin tissue at the base of the lesion. So these are the perforating canals, which perforate through the epidermis or through the follicles. If we go for elastic von Giesen, we can highlight these elastin fiber protruding through the epidermis. So the primary defect is the formation of numerous thick elastic fiber debris in superficial dermis. The distinctive feature is formation of narrow channels through the acanthotic epidermis with elimination of eosinophilic elastic fibers. Histogenesis, thick elastic fibers act as the mechanical irritant or a foreign body. Clinical features, they are generally asymptomatic. Small horny or umbilicated papules are characteristically arranged in lines, circles, segments of circles, or in a serpiginous pattern. You can see this serpiginous pattern or the circular pattern. The individual papules remain small or may enlarge slightly to assume a crateriform appearance with elevated edge and a central plug, or further to leave an area of atrophic skin. The ring may reach a diameter of 15 to 20 centimeter, but may be smaller. Back and side of neck are most commonly affected, but lesions also occur on cheek, arm, thighs, and sometimes bilaterally symmetrical. So this is a characteristic skin-colored keratotic papules arranged in serpiginous pattern. Each of the papule is a small, has a small crater in the middle. The condition which may cause confusion include porokeratosis of mevalli, familial reactive perforating collagenosis, and perforating granuloma annulare, because they all have annular configuration. Then complication and comorbidities, they are associated connective tissue disease, and the condition may persist for several years, but eventually involute spontaneously and leave reticulate atrophic scars. Management. The condition is self-limiting and no treatment is of proven benefit. Destructive therapies include removal of nodules with curettage under local anesthesia and cryotherapy. Excision should be avoided and dermabrasion may make the condition worse. Treatment can be done with lasers, include pulse dye laser, ultra-pulsed carbon dioxide laser, and erbium YAG laser. Topical therapy include the sellotape stripping, then tazarotene, imiquimod, and calcipotriol. Oral retinoid therapy brings some improvement in Down syndrome and penicillin-induced disease. Then perforating folliculitis. Again, this is a questionable term nowadays. It manifests as discrete keratotic follicular papules with predilection of extensive surfaces of the extremities. The disease association include psoriasis, juvenile acanthosis nigricans, HIV, primary sclerosing cholangitis, and renal failure. It has been reported after the use of tumor necrotic factor alpha inhibitors, infliximab and etanercept. Other include sorafenib and nilotinib. The cause of perforating folliculitis is unknown, although minor mechanical trauma may play a role. It is suggested that perforation of epithelium is the primary event and that it is not a primary disorder of transepidermal elimination. So usually in a perforating dermatosis, there is at first damage to collagen, elastin, or another connective tissue structure. And after that, the keratinocyte adhesions become loose and the dermal material is extruded. But in perforating folliculitis, it is suggested that it is primarily a perforation of epithelium, which is a primary event and is not a primary disorder of transepidermal elimination. So you can see this follicular keratotic papule, many a way it resembles the Kyrle's disease. And on histopathology, a curled hair shaft may be seen within the follicular canal. Management. In case of perforating folliculitis, in patients with diabetes and phyrenoderma, skin lesions resolve with correction of vitamin A deficiency. Soothing antipruritic lotions are helpful. UVB irradiation may be of general benefit and control or ameliorate the pruritus. Then there is a term called as necrotizing infundibular crystalline folliculitis. This is characterized by transepidermal elimination of negatively birefringent, needle-shaped crystals similar to monosodium urate. Resolution of the lesion after topical or systemic antimycotic treatment suggests a microbial pathogenesis. So clinically, you can see multiple waxy papules develop with the predilection of forehead, neck, and back. Histology reveals necrosis of the follicular epithelium and sometimes a perifollicular neutrophilic infiltrate. Crystalline deposits with yeast and gram-positive bacteria are found in this follicular ostia. Then acquired pseudoxanthoma elasticum-like syndromes. Transepidermal elimination of altered elastic fibers can occasionally occur in generalized hereditary form of pseudoxanthoma elasticum, but can also occur as a localized acquired defect. These localized lesions usually occur in periumbilical areas in obese, multiparous, Black and Asian women, and it is possible that this represents a response to repeated cutaneous stretching like ascites or previous abdominal surgery. Clinically, asymptomatic yellow macules and papules, which are the characteristic lesion of pseudoxanthoma elasticum, coalesce into well-demarcated hyperpigmented plaques which slowly enlarge. The surface may be atrophic, grooved, fissured, verrucous, and compression of edges of the lesion may produce a liquid discharge. How acquired pseudoxanthoma elasticum-like syndrome is different from elastosis perforans serpiginosa. It seems likely that the most cases previously described as elastosis perforans serpiginosa in association with pseudoxanthoma elasticum are really examples of perforating disorder. The histology of two conditions is similar, but perforating pseudoxanthoma elasticum, there is transepidermal elimination of short, fragmented, and curled basophilic calcified elastic fibers and predominantly occur in mid-dermis, whereas in elastosis perforans serpiginosa, fibers are abnormally large, non-calcified, eosinophilic, and straight. So if the elimination of the fibers are fragmented, curled, and calcified, then it is probably perforating pseudoxanthoma elasticum. But if the fibers are large, non-calcified, and straight, then it is elastosis perforans serpiginosa. So this ends this lecture. Thank you all for a patient listening.